Welcome to the DarshanTalks Pharmacy live stream and podcast. We discuss pharmacy entrepreneurship and issues that may arise. If you like these videos and podcasts, please like, leave a comment, please subscribe. You know you want to. This video and podcast is brought to you by the Kulkarni Law Firm. Reach out to the Kulkarni Law Firm for advice on third-party issues, state board issues, contracting, pharmacy purchase and sales issues, and more, especially in the context of fraud and compliance. Reach out now at darshan@kulkarnilawfirm.com or call me at 302-252-6959. You can also just visit our website at kulkarnilawfirm.com. That's KULKARNI lawfirm.com.
Hey guys, welcome to another episode of Darshan Talks. We have with us the Rudy. I don't know what he's going with today. This is like a series we're doing with him on a SWOT analysis of different types of pharmacies with his perspective. What are some opportunities? What are some weaknesses? What are some strengths? What are some threats? A SWOT analysis, basically, on the different types of pharmacy. What are the opportunities for pharmacists in there? Our guest today is Rudy Dajie, and I'm going to let him introduce himself. Rudy?
Hey guys, Rudy Dajie, pharmacist, entrepreneur, business advisor, all around good guy. That's questionable. And here to talk about some pharmacy stuff. And I think Darshan should change the number to like 1-800, the Board of Pharmacies here or something like that.
1-800, the Board of Pharmacy is here. I don't know if you know how phone numbers work, but they aren't usually that long.
Hey man, you know, in my world, I can have any number I want.
Well, you do own the world. But it's really good to have you, Rudy, because you actually have a ton of experience in that. Can you talk a little bit about your experience, for example? Today we're going to talk about behavioral health. So can you talk a little bit about your experience with behavioral health?
Yeah, that's really where I cut my teeth, is behavioral health. So, and it's all in how you define behavioral health. But generally speaking, behavioral health would be considered organizations like group homes or kids that are in like DCF. So individuals that have developmental disabilities, or it could be people or kids that are in and out of foster care, or sort of can be, children that are problematic. But that you can expand that too, right? Like you can look at sort of this underserved places, prison systems, or jails, or rest homes, or detox facilities. And I sort of lump all of those in with the behavioral health space.
So that's interesting. So it's a pretty wide range of opportunities there as well. Do you tend to find that people, when a pharmacy decides to serve behavioral health as a general audience, they tend to focus on, say, prisons or on, say, foster care, or do they tend to take everything and just kind of go with that?
I think most pharmacies sort of fall into it. I think a group home agency walks in the door of your independent pharmacy and says, hey, listen, we need somebody to provide medications for our patients. Would you be able to blister pack these meds? And somebody says, oh yeah, we can do that for you. And then it sort of sparks a light bulb, and they say, well, and then word gets around, other folks start coming in, and if you're smart, you take all that business and you create a separate long-term care pharmacy so you can bill properly. But I think a lot of folks do the hybrid thing where they're a retail establishment and they just keep doing a lot of this quote unquote non-traditional business. But I think people generally sort of fall into it. They're not really actively seeking it, but then an individual like myself, we went out and actively sought that business.
And when you actively sought it, did you seek any specific types, or did you just say anything long-term care specific in the behavioral health, we'll take it?
We've generally focused on kids' homes and developmental disabilities. That's really where we focused our time. We did a little bit of the drug rehab, but it really wasn't our cup of tea. And there was also, it was a lot more work and a lot more transient. So people were in and out. So you were always having to get new insurance, find their insurance, and then billing always became an issue because who was going to pay for the copays? The drug rehab facility didn't want to pay for them. So it wasn't exactly in my mind, the most efficient business for us, being a very busy organization with servicing over 1,000 group homes across the state. So if I had to get more group homes that the patients are going to be pretty stable and not be transitioning in and out constantly, and have a contact person to get my co-pays paid by, et cetera, and a much more established relationship, I'd spend my time and energy on the group home space. But that was my particular niche. That's where we grew. That's where we focused. It was in that space.
Okay, so you landed up in a scenario where you actually actively went after this space. Let's ask a few questions to kind of get started. We've spoken a little bit about skilled nursing facilities. We've spoken a little bit about independent living and how that gets managed, and just general long-term care as well. I guess my question for you is, what some of the advantages with, say, skilled nursing facilities was that you get to have a formulary, and that means that you can negotiate bulk discounts and the like when you're dealing with pharmaceutical companies, if necessary, if you have enough volume, if you will. Do you have those opportunities in behavioral health, or is it more like independent living facilities where you can't really do that in the same way?
You'd have to spend a lot of energy trying to push people towards formulary medications. And it's just really not worth it. And there's no tremendous benefit other than you trying to negotiate better pricing, right? Because the formula, they're all on Med D, or they're on Med D and Medicaid, or they're on Medicaid. So the agency doesn't see any benefit. And the only time that you can sort of push people is if, say, like there's a new inhaler and you can run a report of all the people on the old inhaler, and you say, okay, look, I'd like to try and transition everybody to the new inhaler, but then you got to go to each individual prescriber and get them to change those meds over. And then the group home kind of gets sort of concerned, like, why is this changing? So there's lay people managing these individuals with developmental disabilities. So they have training, but they really are lay people.
Right.
They're not medical staff. So it's really just not, it's just not a sort of play, or it's not in the playbook generally to go and try to mandate a formulary.
Okay, so let's start from the beginning of what we always do, which is doing a SWOT analysis. We're going to talk about strengths. Do you want to start us off?
Yeah, strengths would be that they're really, it could be a strength or a weakness, but they're a tremendously underserved population. So I think that if you're willing to be a partner with the organizations and really understand the needs that they have, you can easily obtain that business and support that business. They're all dual eligible, generally speaking. So you don't have to worry about people on not on Medicare Part D and uninsured. Yeah. So I think that's the other thing. That's a real strength of that as well. There are challenges, and I know we'll talk about the challenges in a minute, but I think that those are the strengths, and I think that they're an underserved population.
So when you talk about strengths, and you said that you just need to understand their needs better, what did that actually mean? What kind of needs?
So because they're non-medical staff, they don't have the opportunity to not have meds delivered or make judgment calls. So, for example, if they run out of vitamin D1000, everybody in the world as a healthcare professional says, hey, listen, you can have the patient forego that vitamin D. We'll get it out to you tomorrow. It's not a big deal. They can't do that. They can't just make those decisions. So being a partner to them, you have to understand that you're going to have to be on a Labor Day Monday shuttling that medication out to them if they run out. So understanding their needs, understanding that there's certifications that they need, that they get audited by DPH. So if you can go in and help them be prepared for that audit, it's greatly appreciated. We would cycle fill all of their medications. So every 28 days, we automatically push their chronic medications out, and that would help with them not running out of medications. So things of that nature. We would go out and do on-site flu shots so that they wouldn't have to truck their clients to locations. We would go do them in the patient's residences, things of that nature that really end up providing value and separate yourself as a pharmacy versus a pharmacy partner.
So interesting. So what you're saying is that you saw these value additions that they saw value in as well. So my question for you then is, did they pay you for those, or was that out of your pocket so that you're building a relationship?
Yeah, that's all coming out of our pocket.
Got it. So we spoke a little bit about strengths, which is they become partners for life, especially if you understand their needs and they evolve with you, and that's great. Let's talk a little bit about weaknesses. What do weaknesses look like in this space?
Oh, just one other strength. The other nice thing about them is most of these agencies are always trying to grow. And if you're doing a great job and you've pushed to try to be the only pharmacy provider for their agency, as they grow, you're generally going to grow with them. So, that's a nice space to be in.
Very, very true. So your two big strengths are, number one, they're partners for life, and as you grow with them.
Right.
Weaknesses?
So generally these residences are 4 or 5 individuals. So you're doing a lot of deliveries, right? You become a very logistic delivery based business. So instead of delivering to a 100-person nursing home once a day on a structured schedule, you may end up delivering to these locations multiple times a day because there is no structured schedule, right? They go to the doctor whenever they go to the doctor. Somebody may have gone yesterday, somebody may go today. There isn't any sort of rhyme or reason. They don't have a doctor in-house that's prescribing meds, rounding. So, and you're doing a lot more deliveries and a lot more delivery costs. Instead of making 2 deliveries a day to a 100-person location, you're making, 20 deliveries to equal that 100, that 100 beds.
And do you have to eat those costs?
Yeah, no, I mean, we made all of our money on reimbursements. We never charged for delivery fees. We didn't have any fee structure for deliveries, et cetera. So it was purely, a numbers game.
So you had to, as you said, once you have these patients, you have them for life, but they can be expensive patients because there's so much flux in that process. So, so what I'm hearing you say, I mean, in this specific instance, you were working with kids who are going through flux all the time. In a different type of model with a different type of population, say an old folks home for I don't know what the politically correct term for that is. So if someone can educate me, that'd be great. But an old folks home, they tend to be more stable patients in that they've been taking the meds for the last 30 years and they know what meds they're on. They go to the doctor on a routine basis. You can plan that out. Is that a more unusual case to get that type of patient base?
No, I mean, if you have an assisted living facility, you can make those judgment calls. You can have a conversation with the patient. You can say, I'm going to send that vitamin D out on Monday. And those decisions can be made. The problem with the behavioral health space, and they're kids, and they're also a wide range of people that have developmental disabilities too, right? So is that they're required to report everything to DPH if there's missed doses, if there's a med occurrence, everything else. So it becomes onerous on you because any reporting DPH then becomes a pharmacy issue, and then pharmacy has to now respond, right? So then you got to respond every time. So it's really, that's me in my response, like, a ream of paper for every, for a pharmacy response you have to make. So, I think that you really have to understand what you're signing up for when you're willing to work with that patient population.
Very, very cool. So what I hear you saying is there's more paperwork, potentially more cost, a lot more flux. You're obviously helping patients, which is great, but it comes at a cost. But they grow with you, and as long as you're willing to take the good with the bad, that all sort of equals out.
And it's an underserved population, right? So you're not really fighting the OmniCares and PharMericas to manage that business.
Why aren't they going after that business? Just because of the cost associated with it?
Yeah, and they can't manage the logistics. That's not what they do, right? They like having control. They like being able to have formularies, and they like being able to have correspondence with professional healthcare staff. It is a lot to manage when you're trying to manage 1,000 different locations versus 100.
Okay, so once you have the patient base, they aren't going primarily because no one wants to go down that path because it's just a lot. You need a lot more infrastructure to manage that.
Yeah, it's getting more and more competitive. There's a lot more people that are looking at it, and you have to be willing to do 24-hour on-call, be available for med occurrences. So if there's a question, you have to be available to take that. So there's a fair amount of needs that you have to be willing to provide. And if you decide that you want to do it, then I suggest you do it professionally and dive all in versus try to dabble in it. And go after that business and understand the business. So
very, very cool. Let's talk a little bit about opportunities at this point.
Well, I think we've talked a little bit about them. I think they're an underserviced population. I think if you are willing to understand what their needs are, and I think that's in any business, if you're willing to understand the needs of that patient population and the agency needs, it's a great business to have, and you're not facing tremendous corporate competition.
So the big opportunity is really just the fact that no one's really going after it, though that is changing, as you said, over time. But let's explore that a little bit more. Are there some...
And people aren't as sort of price sensitive about stuff either, right? Because they're not paying their bills, right? For the most part, they're dual eligible. So they don't really have these tremendous costs. So if somebody gets put on, I don't know, Ozempic, and their copay is $75, well, that's going to get reduced down anyway because they're dual eligible, and it's going to be $1.10 or $3.25 or whatever it is for Medicaid. So you don't have to deal with that as much. Where in other organizations or other places like, say, assisted living, where it's your mom and you're paying her copays, you're like, oh man, is there something else that she could be on, because I can't really afford $75 every month just for this one med, in copay, plus pay her room and board and everything else. So that's another advantage too, is you don't really have to worry about those concerns.
So let's define the term dual eligible for those people who aren't familiar with it. So what is dual eligible?
So they have Medicare Part D as their primary insurance, and then they have Medicaid as their secondary insurance. So everything rolls, everything that Medicare Part D rolls to Medicaid, that Medicare Part D doesn't pay, rolls to Medicaid. Medicaid picks up the portion, and then they nominal copay structure depending on the state. Every state varies. Some states are much more socialized, or so in those states you're going to have more organizations and more funding for group home agencies and supported living situations. Like Massachusetts is a state like that, right? The deinstitutionalization, and so there's lots of supported living and lots of group homes, and the state, works very hard with that. In other states where they may not have as much funding, there may not be as much opportunity in the behavioral health space. So you have to look at it state to state. So
one of the big issues that obviously comes up in the case of dual eligibles is the idea of billing, because billing can get complicated. Now, did you have like a whole team of people handling billing, or was it relatively done very simply, seamlessly, nearly by a computer system?
No, we had the computer system and we had a team of people. It was both are necessary, in my opinion. And when you talk about billing, there's an adjudication portion, and then there's the people that are calling to say, you got to pay your bill, get the bills out. So in my mind, when you talk about billing, there's two teams. There's the adjudication team that are running the cycles and calling for refills and trying to make those as succinct and complete as possible, and then are processing all the claims, and then working all the rejections. And then the billing team is the team that's sending the bills out every month, making sure everybody's paid up when they need to be paid up, and calling, powers of attorney saying, this, you owe $73, you got to pay, or, blah, blah, blah. So I think that, there's a lot of people involved in that stuff.
Okay. Which brings us to the last piece for a very tight podcast today, but the last piece, which is threats.
Yeah, I mean, I think that there's always threats. So that could be defunding of behavioral health. Funding sources are getting tight and everything's getting squeezed. There could be changes on the way Medicaid and coordination of benefits with Medicare Part D, and they could put more on the patient, and that would be challenging. There could be, I mean, I think other independents are getting into the space and their threats as well. And then nationally, it's getting much more recognized. So private equity was interested in that space, and then you get more and more bigger conglomerates chasing that business. So I think those are some of the major threats.
So that's interesting. Why do you think PE is interested in this space? I mean, one of the things you discussed a few minutes ago was how complicated it gets, and if you don't have the right infrastructure in place, it's really difficult to dominate the space because it is so resource intensive.
Yeah, well, I think behavioral health became like a sexy thing for a little while, and people got excited about it, and so people started putting money. And for me, my business was pretty successful and reasonably profitable. So I mean that piques any PE's business or interest, and they're looking for new places to allocate money, right? Like they're like, okay, like what else can we do? We're tired of buying carpet factories. So they're trying to be innovative and find other spaces that make sense for them.
So you were part of a process where you managed a behavioral care pharmacy. You managed it successfully. You got bought out, I assume, by PE. What are the challenges associated with that? Not necessarily from your specific PE, but as you spoke to other people and the like, in terms of managing expectations. I'm buying carpets today, and I'm buying a behavioral health pharmacy tomorrow. How do you manage expectations as you help people discover the space?
I mean, I think it's really challenging because I don't think a business is business, but the granularity and the nuances associated with different businesses are really where things can kind of go sideways. And I think that it's really challenging for private equity groups you have to find the right private equity group to understand the healthcare space, and specifically pharmacy and specifically behavioral health, because it is such an anomaly that it can be challenging in working with a partner, because the entrepreneurialism and the granularity that we used to deal with every single issue as an individual issue, and not just sort of lump things together and say, oh, well, we'll fix it for next time. And that really made us, a destination. Right? Organizations look for us. We didn't really have to go out and market. We had nurses from DPH that would tell organizations to call us, which was a great space to be. But when you sort of try to put in Gantt charts and like SOPs, you lose some of that, and then you start losing some of the organizations because they like the small pharmacy feel.
And that's a really, really great way to end this. So here's a quick question for you. Any last words?
No, but just focus on the business. And if you're dabbling, then just dive deep in. That's what I would say.
Awesome. These conversations are not intended to be legal, regulatory, or clinical advice and may not be right for you. These conversations are intended for educational purposes only. Conversations on this forum do not create an attorney-client relationship.